Hello everyone, my name is Shayanti with the UNM Division of Community Behavioral Health. Welcome to today's presentation for the Community and Rural Psychiatric Residency Program webinar series. A few announcements before we get started. Please make sure your sound system is muted during the presentation. If you have any question, put them in the chat or feel free to unmute yourself if Dr. Goodman opens the floor. For those requesting a CE or certificate of completion, we will share an evaluation link towards the end of the presentation. You must attain, to receive a certificate, you must attain the full presentation. Also, please note that you will have 48 hours to complete the survey before the links becomes inactive. Without further delay, I will hand it over to Dr. Goodman.
Hello, everyone. Thank you so much for attending today. So my name is Monica Goodman, and I am a resident physician with the UNM Department of Psychiatry. And today's topic that I'm going to be speaking about is catatonia. Next slide. Okay. So brief bio. I grew up in Albuquerque. And after I graduated from high school, I attended the University of Minnesota in Minneapolis for college. I ended up getting a bachelor's in child psychology from there. After that, I moved back home to Albuquerque, went to medical school at UNM, graduated from medical school in 2022. And then after that, I started psychiatry residency at UNM. Right now, I'm in my second year of psychiatry residency. And after I finish residency, I plan to do a child psychiatry fellowship at UNM after finishing, so that I can see patients of all ages. So this was kind of already discussed a little before, but just the procedure for how to get a certificate of completion or continuing education like verification. Yeah. So disclosure, I do not have any financial arrangements related to the content of this activity. And then the views expressed in this presentation are mine and do not necessarily represent the views of UNM. Yeah. So learning objectives. Number one, summarize the clinical features of catatonia while identifying the core feature of catatonia. Number two, identify underlying psychiatric disorders that may be present in patients with catatonia. Number three, assess the long-term prognosis of a patient and predict what treatment will be used based on their subtype of catatonia. Okay, so according to the DSM-5, it is estimated that catatonia occurs in approximately 10% of acutely ill patients in an inpatient psychiatric hospital. So, what is catatonia? I would just like to say before starting this video, catatonia, one of the reasons I picked this topic to discuss is that catatonia is something that's, I guess, less common of a thing for people to know about. I was originally giving this presentation to law enforcement officers, and this is, many of them may be familiar with, like, say, substance-induced psychosis, but, catatonia is something that both police officers and mental health professionals may encounter in their patients, but maybe less common of a thing. And so I thought this would be a more interesting topic to talk about. I actually didn't learn what catatonia was until medical school, encountering a patient with catatonia in the inpatient psychiatry unit at UNM. And so this video that
like a warm candlestick, the body of the patient can be contorted into almost any posture. The patient may maintain the posture for several minutes.
keep playing it, please. So this video is of a real patient, likely from decades ago because the video's in black and white. There aren't a ton of videos on YouTube of real patients, but I feel like this is just a brief video that shows one of the more interesting features that can be present in patients with catatonia, something called waxy flexibility, where patients originally have initially have resistance if you try to move their arms or legs, but that resistance can be overcome and they can be repositioned into a variety of different positions, including positions where the patient is like holding their arms or legs against gravity in a way that would maybe uncomfortable to hold for a long period of time, something that a person would not normally do. And that word is called catalepsy. Basically, it's holding your arms or legs in a position against gravity when an examiner moves your extremities into that position.
Like a warm.
Thank you. So clinical features of catatonia. So the core feature of catatonia is a motor disturbance in which patients are unable to move normally despite full physical capacity in the limbs and trunk. And this basically means that even though someone's muscles are working normally, their nerves are working normally, there's something going on in the person's brain that's interfering with their ability to move as one normally would. Catatonia can range for marked reduction of movements. So someone could be completely immobile, like unable to move at the most severe end of this, or could just be moving more slowly or less frequently. This is called retarded catatonia. It can range from retarded catatonia to excited catatonia, which is the opposite, where a patient might have marked agitation and might be moving very excessively and without like purpose. Catatonia can cause impairments in starting, stopping, and planning movement. So it can be difficult for patients to just initiate movements in general. If the patient is in the middle of doing something like, say, shaking your hand, they may continue to shake your hand even after the appropriate point, where most people would stop shaking the person's hand. They might have difficulty stopping that movement. And then planning movements, patients may get stuck in the middle of doing something. Say they're going to get a drink of water. They may have their arm kind of like get stuck in the middle. It's just difficult for their brain to plan more complicated movements like that. And then movements can be repetitive, so could involve like tapping over and over and over without purpose. So again, kind of random, not like oriented towards a specific goal. Not affected by things in the environment that they normally would be. So sometimes patients, well, I guess a good example would be the previous video where the patient is remaining in these contorted positions that would be very uncomfortable. Usually pain would keep you from staying in that position for a long period of time. And then people can also move in ways that are contrary to what the person intends to do. So they may intend to, follow what direction you give them. When you say, don't shake my hand, they may intend to not do that, but then their brain is not inhibiting that action properly, and they may put out their arm to shake your hand anyways, for example. And I'm just going to apologize. My cat is wanting to go outside, and he can't go outside, so he might be meowing a little bit during this presentation. So the most common features of catatonia: immobility, and this is not due to external stimuli. So it's not due to, say, someone has pain because they broke both their legs. Mutism, so this could be someone is completely unable to talk, or a less severe version of this would be sluggish response to questions, or giving like automatic answers that don't necessarily make sense. So you may ask them a question and they say, "I'm good, how are you?" And that isn't what you asked at all. Their brain kind of just spits out something that's, very commonly said in conversations. Stupor, so this includes decreased alertness as well as diminished response to voice and painful stimuli. So trying to call the patient's name, maybe even doing things like a sternal rub, the patient may be less responsive or unresponsive to these things, completely unresponsive to these things. Negativism, so this refers to resistance to instructions. So it could be telling a patient to do something and they will not do it. It also refers to the general resistance that you find in the person's muscles. When you attempt to move, say, their arms or legs, you're going to encounter a resistance, like a general resistance in all the limbs. Waxy flexibility, this is something that we could see in that previous video, where the initial resistance shown in the patient is gradually overcome, allowing you to reposition them like a candle, is what the video said. Posturing, so this refers to spontaneously maintaining a position for a long period of time. For example, holding your arms above your head. And this is something that the patient does on their own. It's not something that the patient does after being moved by the examiner. It's just something that they do like on their own, staying in kind of an unusual position. And then excessive purposeless motor activity. This can be a symptom of excited catatonia, where someone's just moving a lot. There's no real goal or a reason for the movement. Staring, patients with catatonia tend to have a fixed gaze. They don't scan the environment as much as a normal person would, just really subconsciously looking around at different things, even when you're having a conversation with someone. And then they tend to blink less often as well. Echolalia, this is a senseless repetition of another person's utterances. So if you were to talk to a patient, "How are you?" they would just say, "How are you?" back. And then echopraxia is senseless repetition of another person's actions. So if you were to raise your arm, the patient would mirror what you're doing, like raise their arm after they see you do that. And so this slide and the next slide are going to show the criteria that can be used to diagnose catatonia in the DSM-5. So basically, you need 3 or more of the following criteria. And the symptoms that I'm listing on this page are the same as the symptoms that were highlighted in red on the previous slide. And so the previous slide, it was really all the symptoms except for all the criteria except for 3 are listed right here. So most of the things that we went over and like the most common symptoms seen in catatonia. And for stupor, though, they define it in the DSM-5 as no activity and not actively relating to the environment. So I feel like it kind of combines like stupor and immobility, which was seen on the previous slide. And then the next slide, so, excuse me. So this slide has the remaining criteria. So catalepsy refers to what we saw in that video, a patient remaining in a posture held against gravity when they are moved by an examiner into that position. Agitation, so emotional restlessness, and then mannerisms. This can include behavioral or speech mannerisms. So behavioral mannerisms would be odd, purposeful movements like saluting or holding your hands like handguns. And then speech mannerisms, some examples of those are involuntarily repeating words and phrases over and over, or speaking with like a feigned foreign accent. That could be an example where the patient does not normally speak like this. This is just a manifestation of the catatonia. Grimacing, so odd facial expressions, and then stereotypies or stereotypies. This would be awkward or stiff, repetitive movements with no clear goal. So tapping over and over or rocking back and forth. And this is a behavior, or this particular terminology is also used to describe behavior seen in people with autism spectrum disorder. So like the rocking back and forth or like flapping with their hands. That's an example of a stereotypy. And so this video, I'll just tell you a little about it before we play it. So the University of Rochester has a number of videos on YouTube that show the various symptoms of catatonia and what they look like. They include two doctors who are acting. One is like the doctor and one is the patient. And so I thought it would be helpful to show, this is just an example of a 3-minute interaction where a doctor is examining a patient and kind of evaluating them. It gives you an example of some of the symptoms that may pop up kind of spontaneously. Yeah, you can, thank you so much. There is sound of the video, so it might, I had this happen yesterday. We might need to share it with sound. We might need to stop sharing and then share it again. And then there's a box that says like share with sound when you share something.
So you are sharing.
So when it says share screen and there's like the different options to click on different, yeah, there's like something in I think the lower left corner. Thank you so much. Yeah, I had this exact problem yesterday.
Hello.
Is that okay now?
Yeah, that's okay. Thank you.
What are you doing there?
I'm drinking.
Go ahead and take a sip.
No.
All right. I noticed that your arm actually seems to be levitating as well. Any reason?
I didn't notice it. I didn't notice it. I didn't notice it.
Okay. Let's go ahead and put that down actually then. Let's go ahead and, yeah. How are you feeling right now?
Fine.
Okay, good, good. Let me ask a few routine questions. What's your name?
Paul McGuire.
Okay. Where are we?
Strong Hospital.
Very good. And what state is this?
New York.
Very good. What year is it?
2020.
Very good. By the way, shake my hand.
No.
Do not shake my hand. All right. I'm actually going to examine this arm next. Just relax. Just relax. When I let go, let your arm fall back down to your side. Very good. Okay, perfect. Very good. Keep your arm relaxed.
Feels funny, Doc. Feels funny, Doc. Feels funny, Doc.
Yeah, I see that. Feel some pressure here. Okay, no grasp. Okay, very good. I'm going to put that down. I'm going to come on this side. I notice you're moving your head.
I'm not moving my head.
All right. I'm going to do the same kind of exam on this arm. I'm going to let it go. And when I do, I want you to let it fall back down to rest. Very good. All right, I'm going to move it. Everything's pretty relaxed in this regard, but yeah, same kind of resistance over here too. All right, let's put that back down. Stick your arm straight out in front of you. Very good. Do not let me lift your arm. Do not let me lift your arm. Very good. Okay, go ahead and put that there. One more thing. I have a needle here in my pocket I need to stick through your tongue.
Can't stick that through my tongue. Stick that through my tongue. My tongue. My tongue.
There's actually, I apologize. I didn't mean to cause you distress. There's actually no needle. But I think actually that's the end of our exam. So I'll be right back. I appreciate your time today, Mr. McGuire.
So just to clarify what happened at the end of the video with the doctor saying, I'm going to be sticking a needle in your tongue, you know, through your tongue, like, oh, stick your tongue out so I can stick a needle. What the doctor's doing in that instance, so the Bush-Catatonia, or excuse me, the Bush-Francis Catatonia rating scale is something that is often used to rank the severity of a person's catatonia. And one of the symptoms that they assess for is something called automatic obedience. And one of the best ways to assess for that is to give kind of a ridiculous command that a normal person, if, you know, they heard their doctor saying, you know, stick out your tongue so I can stick a needle through it, would be like, the normal person would be like, hell no, like they wouldn't do it. In a person with catatonia, because their brain's having difficulty inhibiting certain movements, they'll automatically, well, not everyone with catatonia, but sometimes people with catatonia, they'll automatically stick their tongue out if you were to give a command like that. And so it's never the intention of the psychiatrist to actually like stick a needle through someone's tongue. But that was just part of the assessment. And then also with that last video, it's a little hard to see at the beginning, but it showed that the patient's vital signs were normal and that he's eating 3 meals a day, which means that he's definitely not one of the sickest or most severely ill patients. But you could still see a variety of catatonia symptoms in that video. For example, repeating phrases over and over. At one point, the patient was kind of rocking his head, like circling his head over and over, how he was lifting his arm at the beginning against gravity, just doing that kind of spontaneously, having difficulty. So when the doctor asked him, shake my hand, him saying no is an example of negativism, as well as the resistance in all his arms. And then later, when the doctor said, do not shake my hand, the patient became kind of like stuck between going to shake his hand versus not. So these are just kind of a few of the symptoms that I can think of that were apparent in that video. So underlying psychiatric disorders, catatonia is an illness that it does not present on its own. There either has to be an underlying psychiatric disorder or an underlying medical disorder. And so catatonia is most often found in the following psychiatric conditions: bipolar 1 and bipolar 2 disorder, major depressive disorder, psychotic disorders, which could range from something more chronic like schizophrenia to something more acute like a brief psychotic disorder, autism spectrum disorder, and then delirium, which we often see in older patients, but really can happen to a patient of any age, where you see a disturbance of alertness and attention that fluctuates throughout the day, and then an additional disturbance of cognition. So patients may have difficulty with their memory, for example. So one thing that I learned in medical school is that one of the most effective ways to learn a concept is to do a multiple choice question and get the answer wrong. So I did put a couple of multiple choice questions in this presentation just to kind of reflect on. So this question is something I did not know the answer to at all until doing this presentation. I would have completely guessed incorrectly. So this question, catatonia seems to occur more commonly in patients with which psychiatric disorders? A, unipolar major depression, B, bipolar 1 and bipolar 2 disorders, C, psychotic disorders, or D, A and B. And so I'll let you all think about it for a few seconds, and then we can click to the next slide, which will show the answer. So we can go ahead and see the next slide. So the answer is actually A and B, which really, that was not what I would have thought the answer would have been. I would have guessed C personally. But that's just something to be aware of, that both in major depression and a bipolar disorder, that catatonia can happen in these patients, and it's seems to occur more commonly in this patient population versus other patients with other psychiatric disorders. So this is a list of just some of the underlying medical disorders that can be present in patients with catatonia. There was a paper I looked at which ranked a number of causes from most frequent to least frequent. And so you can see that the causes on the top of the page, most of them are involving the brain, as opposed to like another organ. And so inflammation of the brain or encephalitis was the most common underlying medical disorder. This could be caused by, an infection, for an example, like herpes, or an autoimmune disorder. Lupus is an autoimmune disorder that can affect practically like every organ, so it can affect the brain. And then anything that can injure the cells in the brain, like injure the neurons, can lead to catatonia. For example, stroke, toxins or medication. So this could mean starting a new medication, or it could mean stopping a medication. For example, benzodiazepine withdrawal is something that can trigger catatonia. I had a patient who had been hospitalized with catatonia, was given benzodiazepines to treat the catatonia, was discharged with this medication, and then their outpatient provider very quickly tapered them off the medication, and this caused the catatonia to come back. And so this is something that can precipitate an episode of catatonia. Structural brain pathology. So anything like abnormal with the structure of the brain, for example, a tumor, if someone had cancer, seizures, and then miscellaneous conditions like kidney failure or sepsis, which is something that happens with a severe infection. These are just some of the things, some of the underlying medical disorders that can lead to catatonia. So subtypes of catatonia. Earlier, I spoke about how catatonia can exist between, like, there's a spectrum between retarded catatonia and excited catatonia. And truthfully, patients often have symptoms, like a combination of symptoms. So they may not necessarily just be like only on one side of the spectrum. But one of the most important distinctions to make is whether a person has malignant catatonia or just retarded or excited catatonia. And this is because malignant catatonia, you know, the word malignant, you hear it like when you say malignancy, for example, like someone has cancer, you know, it's something that can kill them. Malignant catatonia is a very serious emergency. It's something that can be deadly. Patients may need to be treated like in the ICU. And so, very important distinction. So just to go over some of the symptoms you might see in the different subtypes. Retarded catatonia, you might be more likely to see mutism, inhibited movement, posturing, negativism, so that resistance in their arms and legs when they're being moved, as well as not following directions, and staring. And in severe cases of retarded catatonia, patients may stop eating or drinking, and they may experience incontinence and stupor. So they may have decreased alertness or like response to, you know, to voice or to painful stimuli. Excited catatonia. So with excited catatonia, you'll see excessive and purposeless motor activity, restlessness, stereotypy. So just those like repetitive movements like tapping or rocking. Impulsivity, which could describe something like, say, someone opens a door and the person just runs through the door for no reason, really. They're like, I don't know, like there isn't a clear reason as to why they do this. Combativeness, again, this is, you know, impulsive actions, but this includes things that would be like violent, like hitting a doctor, for example, or another person. And so people with excited catatonia, their movements, which again are not necessarily something they can control, those movements can both result in injury to themselves and injury to other people. And then malignant catatonia, you'll see unstable vital signs, so rapidly changing or elevated blood pressure, fast heart rates, fast respiratory rates, so breathing really fast, extreme sweating, fever, although this is less likely in older patients, delirium, and then the rigidity of muscles. Malignant catatonia occurs suddenly and can progress rapidly within a few days and be life-threatening. So this is, you know, really, really something that can have major consequences, and you know, people need quick medical treatment when this happens. And malignant catatonia, there's a significant overlap with a condition called neuroleptic malignant syndrome, which is a life-threatening emergency, and that's associated with the use of dopamine blocking medications. And there are people who even think of neuroleptic malignant syndrome as a type of malignant catatonia that's like caused by use of dopamine blocking medications. So with that note, this is the second and final multiple choice question. So a patient with catatonia has underlying schizophrenia and normally takes an antipsychotic medication called haloperidol or Haldol daily. This medication works by blocking dopamine. Should the psychiatrist continue to give this medication while treating the patient's catatonia? Yes, the patient should continue to take this medication as they normally would. B, no, antipsychotic medication can worsen catatonia. Or C, yes, and the psychiatrist should increase their dose because antipsychotic medication can treat catatonia. So I'll let everyone think about this for a few seconds and then we can proceed to the next slide. Okay. So the answer is no. Antipsychotic medication can worsen catatonia. And so this doesn't necessarily mean that the patient, once they get better, once the catatonia resolves, that they can't take that medication again. Certainly if someone has like schizophrenia or bipolar disorder, for example, they might need to take an antipsychotic medication to treat their chronic mental illness. But this is something that would need to be started under like observation, like monitoring from a psychiatrist, and not just be maybe not necessarily restarted like at this, if they were taking it at a really high dose. You might need to like start it up more gradually and just monitor them to make sure that the catatonia does not come back. So treatment for catatonia. So you will see that the treatment algorithm, like the first line treatments for catatonia, differ a little bit, again, based on whether a patient has malignant catatonia or if they just have retarded or excited catatonia, so non-malignant catatonia. So treatment for catatonia. So some important principles. If a patient has an underlying medical condition that is contributing to the catatonia, it's very important to treat that condition. So if someone had a stroke, for example, you make sure and treat that. Or if someone's having seizures, you want to treat that. Avoid dopamine blocking drugs. So any antipsychotic drug you want to avoid, particularly at the beginning. And then there is actually a medication called Phenergan or promethazine for nausea that is also a dopamine blocking drug. So that's another medication that you would want to avoid. And so one of the first things that doctors do that can both help with symptoms temporarily, but also can help with diagnosing catatonia is something called the lorazepam or Ativan challenge. And so you give a patient maybe like the example given, I think that I saw was 1 to 2 milligrams of Ativan IV. You don't necessarily have to give it IV. Like in the inpatient psychiatric hospital, you can't give IV medication. So you could give it orally if the patient's able to take oral medications, or you could give it intramuscularly. So if the patient is not able to take oral medications. But if you see a partial temporary relief of signs 5 to 10 minutes after administration of the medication, this is consistent with the diagnosis of catatonia. If you do not see a response, that doesn't rule out catatonia. 20% or more of patients do not respond initially. It could be that they need a higher dose. And then, so for patients with malignant catatonia, they would basically start off with a benzodiazepine, like lorazepam, for example, plus immediate preparation for ECT or electroconvulsive treatment. And so if a benzodiazepine provides substantial response within 24 to 48 hours, you can just continue that instead of going to ECT. And then mortality increases if ECT is not begun within 5 days of treatment for progressive malignant catatonia. And so ECT, a lot of people, when they hear ECT, they think of, you know, the movies, like the Hollywood movies showing people getting shocked and they're in severe pain and their muscles they're just convulsing, and it's a horribly traumatic experience. And obviously we all know as mental health providers that ECT, the way it's portrayed in movies, is far, far different from how it's actually conducted in the hospital. Patients, they are put under anesthesia, so they're asleep. They're also given medications that keep their muscles from like convulsing. So they have a very short seizure and their head moves like a little bit. But it's really nothing like what is portrayed in the movies. And the person's asleep, so they don't remember what happened. And as we know, ECT is something that not considered lightly, but if someone has a life-threatening condition like malignant catatonia or severe depression, for example, it can really be a life-saving thing. And then for patients with retarded or excited catatonia, you would just stick to like a benzodiazepine like lorazepam, which is most often used, although you can use other benzodiazepines. And then for patients who do not respond to benzodiazepine use within 1 week, the next step would be ECT. And with these guidelines, 60 to 80% of patients make full recovery. And so long-term prognosis. So for patients with malignant catatonia, death rates of up to 20% have been reported. So most people recover and they survive, but the long-term prognosis is worse for patients with malignant catatonia. Patients may also have permanent deficits when they recover, for example, cognitive deficits or apathy syndromes where they're just not experiencing the full range of emotions of a normal person. And then for patients with retarded or excited catatonia, there is a generally favorable prognosis. So patients who have an underlying bipolar or depressive disorder, for example, which these are the most common underlying psychiatric disorders, usually the catatonia resolves with treatments. However, catatonia may last for years in some patients, particularly in patients with schizophrenia. And so with these patients, they may need to be discharged with benzodiazepines as an outpatient, and they may need to continue taking that medication for a longer period of time. If that medication is decreased, it needs to be done very, very slowly, gradually, and with frequent monitoring from a doctor to make sure that they're not going back into catatonia. And some patients, even if you decrease the medication gradually, they just reach a point where if it's too low, they'll go back into catatonia, and these patients may need to be on the medication for a longer period of time. Okay, so this is my final slide because I like cats. And so the next slide is just references, and this version of the PowerPoint doesn't have the QR code, but we can pull it up. But thank you so much for listening, and if anyone has any questions, I'd be happy to answer them. I also want to thank Psychiatry for helping with moving the slides along because my computer was freezing and not cooperating. So I really appreciate that.
Thank you, Dr. Goodman, for a wonderful presentation. And I was sharing, that's why I couldn't share the QR code or survey link. Give me a few minutes. I will share the survey link in the chat box.